Hi everyone, my name is Peter. Welcome to my YouTube tutorial. In this section, I'm going to be discussing about the anti-seizure drugs, and specifically we shall look at the group called the Phenytoins. So under this group, we have drugs such as Phenytoin, Phenytoin. Those are the mostly used drugs right now in as far as anti-seizure management is concerned. So under my objective, we shall look at the mechanism of action of Phenytoin. Then we shall briefly look at the bioequivalency, then the side effects of this drug. So therefore, let us jump into the first objective. Before that, I have a structure here called the uridine structure. So we shall refer to this structure more as we go on in the anti-seizure drugs, because most of these drugs have this structure. So in phenytoin, the R1 and R2 have what we call two benzene rings, and then the X is has a nitrogen and a hydrogen on it. So therefore, this structure is very important as far as discussing anti-seizure drugs is concerned. So therefore, let me go straight to the first objective, which is the mechanism of action. So we see that phenytoin inhibits what we call the sodium channels. These sodium channels are very important in the propagation of the impulses that we see in the neuron. So therefore, these highly frequent firing neurons in the focal area in the brain where we have a seizure point are usually reduced, or because phenytoin has what we call a use-dependent mechanism, so it inhibits more of those highly firing neurons. So therefore, as the effect, it will lead to the prolongation of the inactivated state of the sodium channels. So therefore, to drop to the second objective, which is the bioequivalency of phenytoin. So phenytoin has what we call very poor solubility. So therefore, we see that we do not usually give phenytoin as an IV, because phenytoin exists as a sodium salt at a pH of 11 to 12. So therefore, when we inject this salt into the blood, it will form a precipitate, because our blood has a low pH of about 7. So therefore, that drop in pH will result to the precipitation of phenytoin at the site of injection, and this will lead to damage to the site of injection. So that is a point to note when giving phenytoin. So this poor solubility problem was solved by introduction of another new drug called phenytoin, which is basically the phosphorylated phenytoin, whereby they replace this hydrogen with a phosphate group. So this phosphate group improved the solubility of phenytoin. So we can give phenytoin in status epilepticus, we can give it in partial seizures and complex partial seizures. So and another important factor about the phenytoin capsules is that they usually absorb carbon dioxide. So when they do that, carbon dioxide, remember, like I said, phenytoin salt exists at a pH of 11 to 12. So when carbon dioxide is absorbed by this salt, it's going to lead to the drop in pH. So when the pH drops, we precipitate out the phenytoin salt. So this results in very poor oral bioavailability. So that is all about the bioequivalency of the drug. So let us drop to the side effects of the drug. So one of the side effects that we note are the peripheral neuropathies. These are very common when you take the drug for a long time. Then another side effect to note is nystagmus. Usually this is a vertical nystagmus, which involves the movement of eyes up. And another side effect seen here is the ataxia, unable to balance. And studies show that a person who has taken phenytoin for a long time has a reduced cerebellum. Then another side effect is gingival hyperplasia, so common. Then another one is dysarthria, which is slurred speech. So this is due to the action of this inactivated sodium channels. So any propagation in neurons may be affected, especially the neurons that serve the muscles for we use for speech. Then we shall look at what we call the drug-induced hypersensitivity. So they say that since phenytoin has two aromatic benzene rings, so during the metabolism of this drug, these benzene rings produce what we call immune inducers. So these immune inducers are said to have an effect on causing these hypersensitivities. Then another side effect to note is the folate deficiency caused by phenytoin. So now, since phenytoin causes folate deficiency, it is contraindicated in pregnancy, because we know that folate is very important in formation of the nucleic materials. So we do not give phenytoin in pregnancy. So that is a big point to note. So another bioequivalence point that I had forgot to talk about is that it's phenytoin has it's very hard to dose, because any slight increment in a dose may lead to toxicity. So at low doses, phenytoin will exhibit what we call a first order kinetics, whereby any increase in any increase in dose leads to an increase in concentration in the blood. So if I double the concentration, if I double the dose, I'll also double the concentration in the blood. Then there is what we call a Vmax, at a point where the maximum dose that I can give a patient. So if I exceed that maximum dose, any slight milligram that I add on that might lead to toxicities, and it will precipitate all these side effects that we've seen here. So in the last point to note here, I have what we call phenytoin has what we call is an inducer of the cytochrome P34A enzymes. So this any drug which is metabolized by this enzyme will be metabolized very faster compared to the normal mechanism. So the cytochrome P34A inducer affects drugs such as carbamazepine, felbamate. We have theophylline, we have warfarin, we have contraceptives, and very many other drugs. So therefore, when you're giving phenytoin together with these drugs, you have to be cautious, because the phenytoin will induce these enzymes which will metabolize these drugs very fast, and it might affect, especially these anti-seizure drugs, it may affect the management of seizures. So therefore, thank you very much for watching. So this was just discussing, I was only talking about the phenytoins. In my next sections, I'll be discussing more of other anti-seizure drugs. Thank you very much. Bye for now.